The following lecture is aimed for senior dental students, interns, dental trainees, oral surgery and oral maxillofacial surgery residents, as well as master and doctor degree candidates. In memory of my late parents, may Almighty merciful God rest their souls in heaven and peace. So first of all, please allow me to give a brief bio about the speaker. My name is Muhammad Ahmed Al-Shulqami. I'm currently a professor and the chairman of the Oral and Maxillofacial Surgery Department at the Faculty of Dentistry, Suez Canal University in Ismailia, Egypt. Actually, Ismailia is one of the most beautiful cities in Egypt. It is located around 80 miles to the eastern of Cairo, overlooking the Timsah or Crocodile Lake and Suez Canal. Ismailia was founded by and named after one of the great rulers of Egypt in the 19th century. He was Ismail Pasha or Khedive Ismail. He was the one who did the opening ceremonies of the Suez Canal in 1869. Beautiful scenery is always seen in Ismailia. You have a greenery landscape overlooking lovely blue sea, and I think it's worth visiting. And that's the place where I work. This is the Faculty of Dentistry complex. It is comprised of 3 main buildings. I'm also the professor and the supervisor of the Oral and Maxillofacial Surgery Department at Faculty of Dentistry, Sinai University, Kantara campus in Ismailia. I also worked as a part-time associate professor at MIU University and MSA University for several years. I'm a visiting professor at the Faculty of Dentistry, Beirut Arab University, in the Oral and Maxillofacial Surgery Department in Beirut, Lebanon. I'm also the managing director of the Egyptian Dental Center, a multi-speciality discipline dental and maxillofacial center based in Cairo, Egypt. Our topic is one of the most important and practical aspects of maxillofacial infection management, which is incision and drainage. What are the main ILOs? Understand the definition and advantages of incision and drainage, knowledge of different indications, understand the appropriate timing for performing incision and drainage, understand the principles of incision and drainage, and last but not the least, knowledge of intra and extra-oral locations for incision and drainage of different spaces and locations. By definition, incision and drainage involves evacuation of accumulating submucous or subcutaneous pus in the maxillofacial region through incising the skin or the mucosa with a thin-tipped blade. What are the advantages of incision and drainage? Finding an outlet for bacteria and their toxins and getting rid of them, pain relief, distension relief, prevention of further spread of infection and pus, saving the body from systemic effects, and last but not the least, permission of more efficient body defense and improvement of the immunity. What are the indications for incision and drainage? Presence of odontogenic infection, post-operative infection, infection associated with trauma or compound jaw fracture, osteomyelitis cases, and last but not the least, nosocomial infection, which is infection acquired in a healthcare facility or hospital, whether post-operatively or during a course of care. So what is the optimum time for incision and drainage? Or in other words, what are the clinical diagnostic criteria or clues that can tell the dentist or the maxillofacial surgeon about the optimum time to incise and drain? Fluctuation test, or presence of fluctuation in the collection of pus. Second, pitting on pressure. Third, presence of erythematous red halo. And last but not the least, aspiration of pus from facial cellulitis swelling. On the right hand side figure, you can find, if you put your pressure on the swelling, there's pitting or indentation resulting from the pressure or the finger pressure of the operator. It is pointed to by the 2 black arrows. On the left hand side we can find a red erythematous halo in the cellulitis swelling, and it is pointed to by the two red arrows. Furthermore, when you have a hard swelling or cellulitis swelling and you feel that this swelling might by default might have some pus, you can resort to aspiration deeper in this swelling or in the deepermost parts of the swelling, and some authors advocate to perform aspiration of pus for confirmation for performing incision and drainage, and other authors they do not advocate this technique. Coming to the principles of incision and drainage, first of all let's start intraorally, knowing the blade and the armamentarium needed for incision and drainage. Horizontal incisions are usually performed in the mucosa. The parietal abscess should be incised in the alveolar mucosa to avoid injury to the greater palatine artery and nerve. Likewise, the lingual abscess also is incised in the lingual mucosa to avoid injury of structures, vital structures passing the floor of the mouth, like the submandibular gland duct and the lingual nerve and blood vessels. Blunt evacuation should be done. This is the blade used for incision. It is blade number 11. It is a thin tipped blade and it's called the stab incision blade. And in all instances, you should always bear in mind that the removal of the causative factor is crucial, and it should be done with incision or drainage or prior to incision and drainage as well. These are the armamentarium needed besides the blade: the straight or curved hemostats or RT forceps, Kelly hemostat or the mosquito RT forceps. On the left hand side below we can see the rubber drain, sterile rubber drain. We can cut what we need and we place it inside the incision, and then we can secure it with sutures. This is a diagram representing introduction of the hemostat in a closed fashion and then opening it inside. This is what we call the blunt evacuation, and it goes in different directions and different tissue planes and beneath the muscle fibers and in between the muscle fibers to evacuate all pus which is entrapped beneath the muscles. And finally we introduce the rubber drain, and then we make security of this drain with sutures, whether with the mucosa or with the skin extraoral. The intraoral incisions, the red arrow is pointing to the upper vestibular incision to evacuate the canine or the infraorbital space, and the black arrow is pointing to the parietal space incision. On the right hand side, the upper incision shows the peritoneal space incision, followed by the sublingual space incision, the lingual mucosa, and finally the mandibular vestibular anterior space incision. On the left hand side we can see the buccal space incision in the lowermost part of the buccal space, and also this incision, if we extend it posteriorly a little bit to the anterior border of the ramus, we can use it to incise or drain the masticator space and the lateral pharyngeal and pterygomandibular spaces. In cases when we deal with the sublingual space infection or abscess, the incision is done horizontally in the floor of the mouth, but with special precautions to avoid injury to the sublingual salivary gland causing ranula, or injury to the submandibular gland duct or lingual nerves or lingual blood vessels. So it is carried out lateral to the plica sublingualis, shown in the figure in the lower left hand side figure, or in the clinical photo on the right hand side. It is done lateral to the sublingual plica, near or towards the alveolar lingual mucosa, because if it is done over this plica, it is going to injure the sublingual salivary gland, leading to ranula or damage to the gland. And if you go further medial to this plica sublingualis or the sublingual plica, you will injure the submandibular duct and the lingual artery and lingual nerve. This figure shows the incision done at the anterior border of the external oblique ridge to reach the masseteric space laterally on the lateral aspect of the ramus of the mandible, or the pterygomandibular space on the medial aspect of the ramus of the mandible, and the curved dotted arrow points to the lateral pharyngeal space. You go further medially to evacuate the lateral pharyngeal space. And so we place the drain and secure it by sutures, and finally give the patient the post-operative medications, the antibiotics and the painkillers, and either warm mouth rinse or warm fomentations, and supportive treatment as well, and very good nutrition and fluid replacement. On the left hand side we can see the vertical placement of the incision at the anterior border of the ramus to target the infrazygomatic portion of the masticator space, which have two compartments. Medial to the mandible we have the pterygomandibular space, and lateral to the mandible and medial to the masseter muscle we have the masseteric space. And we can go further, as we see on the right hand side figure, we can go around the corner to the lateral pharyngeal space as well. And in this figure we can see the proper placement, posterior superior horizontal placement of the incision to evacuate the infratemporal space abscess. It is done lateral and superior and buccal to the last molar tooth. What about the extraoral incisions? The blade used for incisions. Some authors advocate the use of blade number 10 as they consider this an extraoral or skin incisions. Others advocate the stab incision or the blade number 11, and I'm one of them actually. In case of presence of fistula, how should it be treated? Incision is always done at the lowest point or the most dependent point, which we feel that it is going to evacuate the abscess completely. However, this is not the case in all instances. Through and through incision should be done by introduction of the drain from one incision and getting it out through the other incision, like what we do in Ludwig's angina. Blunt evacuation is done in the same fashion as the intraoral incisions. Drain security is done through sutures, and post-operative care including antibiotics, analgesics, supportive treatment, multivitamins, good nutrition and fluid balance. This is the through and through fashion, introduction of the drain and dissecting it using the mosquito and hemostat, and introduction of the hemostat from the other outlet, and then pushing from one side and pulling the drain from the other side and getting it out from the other exit, and then securing by sutures. And here's the diagrammatic representation of the locations for different fascial spaces, extraoral incision. In the anterior region we can see the submental behind or below the chin, and lateral aspect, the submandibular below the inferior border of the mandible. Going posteriorly around the angle we can incise to drain the submasteric and pterygomandibular spaces, and on the lateral aspect of the border of the sternocleidomastoid you can see the curved incision for the lateral pharyngeal space and the upper portion of the retropharyngeal, and just parallel to the sternocleidomastoid we can drain the carotid sheath and retropharyngeal space, and upwards and superiorly we can see the temporal space incision, the horizontal incision in the temporal region. And this is the diagrammatic representation showing the horizontal incision for the submental space, and on the right hand side we can see a clinical photo showing incising the submental space below and behind the chin. And this is the diagrammatic representation of the incision of the infratemporal space abscess. It is just a horizontal incision just posterior to the junction of the temporal and frontal processes of the zygomatic bone. And these are clinical photos showing a temporal abscess being incised and drained. On the right hand side we can see the mosquito introduced through the incision line, and blunt evacuation is done, and after penetrating the muscles and going beneath it, we had on the left hand side oozing and draining of the pus mixed with blood. Post-operative care, put Barton bandage, clean and sterile bandage and dressings over the incised area and over the drain, secured with sutures. And as previously mentioned, in case that we have infection, neglected facial spaces infection, or delayed in drainage, this might lead to spontaneous sinus draining, which will be eventually epithelially lined into a fistulous tract. So we need to eradicate and completely remove this fistulous tract and do undermining in the skin and have some cosmetic sutures using horizontal or vertical mattress suture with 4 or 5 0 suture. And let's not forget our golden rule regarding incision and drainage. Don't let the sun set on undrained pus. And finally, I would like to thank you for your kind attention. Thank you so much.